webinars. Greetings to you from Mumbai, the city that never sleeps. I'm Dr. Ameet. Many years back, Voltaire had said that the art of medicine is to amuse the patient while nature cures the disease. And this cannot be more true for polycystic ovaries because we know that in polycystic ovaries, most women, if they look after their lifestyle disorders, their weight and their eating habits, half of their problem will get solved. There's even a more older saying which says, we teach best of things, we want to learn more. And that cannot be more true in myself because polycystic ovary has intrigued me for the last 20 years that I'm into fertility practice. So ladies and gentlemen, have we reached the crossroads in management of polycystic ovaries? There is such a large armamentarium of therapies that are involved that we really need to think and choose which path we need to go for a particular patient. But what exactly is polycystic ovary syndrome? Way back in 1990, the NIH and the NIH-CD conference on polycystic ovarian syndrome, where it was a meeting of all so-called experts, no single PCO criteria was endorsed by more than 65% of the so-called expert respondents. At the end of the two-day meeting, they came to a consensus to say that insulin resistance, increased LH-FSH ratio, and polycystic ovaries on sonography could be regarded as possible criteria to define and diagnose PCOS. Later, the Rotterdam ESHRE ASRM joint consensus of 2006 said that any two of the three following conditions could be labeled as PCO: oligo or anovulation, clinical or biochemical hyperandrogenemia, and PCO on scan could be regarded as polycystic ovaries. So either the patient had oligo or anovulation, clinical or biochemical hyperandrogenemia, and PCOD on sonography could be diagnosed as PCO. Michael Crichton, a medical critic and a writer, in one of his review articles said that there is no such thing as consensus in science. If it's consensus, it isn't science. If it's science, it isn't consensus, period. He further went on to elaborate and explain what he meant by saying that consensus is invoked only in situations where the science is not solid enough. And that was what was precisely the ESHRE ASRM consensus of 2003. So even the best of the scientists, the best of research people in PCO couldn't identify more than three diagnostic criteria or could not agree on any more. So mere mortals like us would definitely either underdiagnose or overdiagnose PCO. But thankfully in 2018, we have this excellent exposition of international evidence-based guidelines for management and assessment of PCOS. Again, a joint ESHRE ASRM along with Monash University has come up with this brilliant overview. But why is PCO so relevant to our practice, particularly in infertility? It is the most common endocrine dysfunction in the fertile age ranging from 14 to 45. It can occur in women up to 18% in the reproductive age. And not only in the reproductive age, but even later on, it is associated with abnormal GTT, increased risk of type 2 diabetes and hypertension, fibrinolytic and lipid derangements are observed in PCO patients. So, one of my first take home messages to you today, ladies and gentlemen, is that don't ignore your PCO patients after they've had their childbirth. But I think they need to be reviewed, they need to be reassessed because they are at a high risk of abnormal GTT and type 2 diabetes and lipid derangements and the lifestyle disorders. The medications that you tell them should be continued even after they've had their children. So when you break them up into phenotypes of PCO, the first type 1 classic phenotype is the one with hyperandrogenemia, chronic anovulation, and polycystic ovaries, which will make up almost 54 to 55% of all PCOS. And this is the most common presentation that we would see in our outpatients. The type 3 phenotype, which is hyperandrogenemia and polycystic ovaries on sonography, but perfectly ovulatory regular cycles, constitutes almost one third of PCOS, which may not necessarily come to you for infertility, but may come to you later on for irregular periods, DUB, or even obesity. The type 2 phenotype is hyperandrogenemia and chronic anovulation, but the ovaries look perfectly normal on sonography, which constitutes 9% of your PCOS. And the type 4 is chronic anovulation and polycystic ovaries on sonography, but no biochemical or clinical signs of hyperandrogenemia, which would constitute approximately 8% of your patients. So type 1 and type 3 would constitute almost 80% of your patients, and these are the most common presentations that would come to your clinic. So if you look at an ovulation as a primary symptom that they would come, there are various other reasons for a woman to have anovulatory cycles, but the most common is polycystic ovaries. We then have women, which we see nowadays because we are aware of premature ovarian failure, who also come to us with chronic anovulation and irregular menses. Women with autoimmune disorders, women with genetic diseases, particularly Turner's or Turner mosaic patients, and patients who have got iatrogenic amenorrheas, either because of radio or chemotherapy or some other cancers. The other endocrinological reasons for an ovulation, which we must commonly rule out, is thyroid, particularly hypothyroidism, and even in that, subclinical hypothyroidism, where the TSH levels may be within the lab designated levels. But to be very honest, in a fertile woman, we need to have the TSH between 2 to 4, although the lab normal values may be from zero point 0.6 to 5 or even 6. Subclinical hypothyroidism is one of the most common causes of anovulation, and it will also present as hyperprolactinemia in some cases. The other rare cases could be adrenal disorders, in that congenital adrenal hyperplasias, Cushing syndrome, and adrenal tumors. So how do you manage PCO? It really depends on what the woman has come to you. We get young girls who come with PCOS, particularly because their mothers are more worried about their irregular periods. And I think besides offering them lifestyle disorders to start, if they are obese, introduce some exercise, some diet restrictions in them to regularize their periods, the use of the birth control pill, or the combined oral contraceptives is excellent. It not only regularizes menses, but also will work as anti-androgenic and will take away the hyperandrogenemia, particularly acne, pimples, and male type of baldness, or even increase facial hair or body hair. Persistently and ovulatory cycles have very high LH levels, and the COCs will help to reduce these LH levels, thereby allowing them to get regular periods after they have started losing their weight. There are certain women who want to maintain their fertility potential, may not be eager to conceive, so do not want fertility treatment, but would at the same time want to get regular menses. These are typical women who have PCO, who already have maybe a child, are keen to have a second child, but do not want to be labeled as subfertile. The use of progestogens for regular menses is another very brilliant idea which will help them to not only regularize their menses but will also prevent endometrial hyperplasia in this group, thereby reducing their chances of getting any increased mitotic activity in their endometrium, thereby reducing their chances of getting CA endometrium in latter years. Progestogens need to be given cyclically for 10 days to ensure that they get regular menses. We also have women in whom we would like to get at least 4 to 5 periods in a year. So they need not get periods every month. You can prescribe the progestogens to them every 6 to 8 weeks so that there is regular shedding of the endometrium, which is very important. And at the same time, there are safer progestogens in case if they are keen to conceive, which will help the ongoing pregnancy. So when you look at the 75% of women who come with an ovulation, irregular menses, suggestive of polycystic ovaries to their outpatients for primary or secondary infertility, the main thing you need to treat is their an ovulation. And clomiphene citrate has established itself as the benchmark treatment for the last 40, 50 odd years. The mode of action, we all know, it acts on an intact HPO axis, very important to know. It has a negative feedback mechanism, thereby increasing the FSH levels, thereby increasing the stimulation to the primordial follicles. Clomiphene citrate will not only cause follicular growth and maturation, but it is also known to give a multifollicular response. So who will respond to clomiphene citrate? Women with normal responses from the hypothalamus and pituitary to low estrogen levels. So it works as an anti-estrogen, reduces the estrogen levels, thereby stimulating the HPO axis to release FSH, which will then stimulate the ovary. So clomiphene is to be given in women in whom HPO axis is intact. If you have women where the HPO axis is blocked because of some pathology or because of some drugs like a GnRH depot, then clomiphene citrate will fail to act in such women, and that is something that we should be aware of. So indications to use clomiphene would be ovulation induction in an anovulatory or an oligo-ovulatory cycle, ovulation augmentation, multifollicular response in an unexplained ovulatory infertility, or a controlled ovarian stimulation, particularly when you're using mild stimulation in ART cycles. Obviously, every drug has its disadvantages, drawbacks, and although ovulation rates are high, pregnancy rates with clomiphene citrate are relatively low, and this is because of its peripheral anti-estrogenic effect. Clomiphene has a long half-life and ideally should not be given in back-to-back cycles because it can have a cumulative effect and the endometrium lining can get severely disimpaired. It has got higher than expected miscarriages. And if you realize that your patient conceives but miscarries on clomiphene, I think you should stop using clomiphene and move straight on to gonadotrophins. Clomiphene, because of its long half-life, has a negative effect on the endometrium. So although you would get ovulatory cycles, the endometrium is not optimum for implantation and hence the low success rates. So when you reach at such a crossroad, you have an alternative, which is letrozole, a triazole third generation non-steroidal aromatase inhibitor, one which works with competitive inhibition, highly selective, by far and large will give you a monofollicular development, an extremely potent drug. And now in the new 2018 assessment and management of PCOS, letrozole is the first drug of choice for ovulation induction in a PCO patient. In a non-PCO patient, clomiphene citrate still retains as a drug of choice as a first line treatment in non-PCO infertility. As I said, the action is aromatase inhibitor. It has a short half-life, thereby its negative estrogen effect quickly wears off and doesn't decrease or impair the implantation, and hence having same ovulatory percentages, it has got a better pregnancy rates because of its low half-life or short half-life. And the other advantage is that letrozole can be used in back-to-back cycles, thereby decreasing the time required to conceive in a particular patient. The dose is 2.5 milligrams to be given for 5 days, to be started on day 2 or day 3 of the cycle. So when you compare clomiphene and letrozole, you find that the depletion of estrogen receptors in endometrium happens in clomiphene but doesn't happen in letrozole. The endometrial thickness is not remarkably affected in letrozole cycles as much as it is affected in clomiphene, thereby giving you a decreased pregnancy rates in both but more in clomiphene citrate. Half-life is much longer in clomiphene, but very short, almost 2 days in letrozole, and the blood flows are contrarily increased in letrozole cycles, thereby offering you better blood supply to the uterus and better implantation rates, and hence the pregnancy rates are better in a letrozole cycle. But both letrozole and clomiphene need monitoring, although the risk of hyperstimulation is low, but it is not only a theoretical but a genuine risk of hyperstimulation, particularly if you use it in multiple cycles. And hence there is always a need for a newer agent, particularly which can be given orally and needs very less monitoring and without risk of multiple ovulations or multiple pregnancies. Before I come on to the drug, let me tell you the key pathogenesis for PCO, which is insulin resistance. So insulin resistance and thereby the compensatory hyperinsulinemia is the key in the pathogenesis for polycystic ovary syndrome. It is present in almost all obese patients, 80% of obese PCOS. But to your surprise, 30 to 40% of lean women also have hyperinsulinemia and hence need to be treated with insulin sensitizers. So 80% of obese PCOS and 40% of lean PCOS would have insulin resistance, and this is something which will affect them through their life, increase risk of cardiovascular disease and other metabolic disorders. So the insulin resistance will give them hyperinsulinemia. This hyperinsulinemia will give rise to hyperandrogenemia, which will give rise to polycystic ovaries. And then you have the full symptomatology of menstrual irregularities, acne hirsutism, obesity, and infertility. So the role of insulin sensitizers is to increase the sensitivity of insulin towards the receptor, thereby reducing hyperinsulinemia. So for the same gram of glucose, if a non-PCO needs X amount of insulin, a PCO patient may need 3x or 4x amount of insulin to counter that glucose. And hence they have hyperinsulinemia, and that is what leads to fatigue of their pancreas and diabetes in latter years. We have myoinositol and D-chiro-inositol as other options to treat that hyperinsulinemia. The myoinositol is linked to cellular glucose uptake. It increases the glucose uptake, present in high concentrations in the ovary, present in the follicular fluid. And I was surprised to know that that myoinositol was introduced into the market many years ago as an antioxidant and not for use in PCO patients. The D-chiro-inositol is present in high concentrations in glycogen storage tissues such as the liver, muscles, and fat. It has no effect on the ovarian level. It is linked to glycogen synthesis. It rapidly reduces peripheral hyperinsulinemia. So both of them are working complementary to each other. The myoinositol increases glucose uptake. The D-chiro-inositol will reduce insulin production and hyperinsulinemia. And D-chiro-inositol, by reducing hyperinsulinemia, reduces conversion of myo to D-chiro at the ovarian level. And myoinositol will act at the ovarian level, thereby improving the ovarian quality and the possibility of oocyte maturation. And that is one reason why myoinositol will work well in PCOS, because we know now that PCOS may give you large number of oocytes, but quite often their fertilization potential is low and they have some epigenetic problems, and these can be restored by use of myoinositol in their treatment armamentarium. So a dichotomy is present with peripheral tissue insulin resistance and ovarian insulin sensitivity. So despite a systemic state of insulin resistance, the ovaries remain insulin sensitive, and subsequent androgen production is called as insulin paradox. And hence, myo and D-chiro have to be in a synchronized levels, in a level of 40:1. I will come to that later. But needless to say that myoinositol improves oocyte quality, helps in oogenesis and oocyte maturation, and only myoinositol has the ability to reduce the recombinant FSH administered. Now, what are the dangers of very high levels of D-chiro? They are known to be toxic to the ovary, toxic and at high levels will impair estradiol synthesis, and hence a higher D-chiroinositol formula was ineffective, or more important, had negative effects on clinical outcomes because it reduced the ovarian quality. So the ideal physiological ratio of myo to D-chiro is 40 is to 1. At this level, there is effective glucose uptake and utilization and normal insulin sensitization. So a combined therapy of myo and D-chiro will reduce the effect of metabolic disorders in PCO, particularly the obese overweight PCOS, as compared to myo given alone. So the crossroads at this level is, what is the ideal dosing frequency of inositols to be taken once or twice? So the suggested use is myo to be used exclusively in young adolescent PCO girls, in thin lean PCO girls, in ovulation induction for PCOS, and in PCOS women with risk of GDM. Myo and D-chiro combination to be given in the obese PCOS or the obese infertile PCO patients. And the third group, which I'll come to now, is a combination of myo with metformin, is to be reserved for obese PCOs with severe insulin resistance, not working to either myo or metformin alone, and in perimenopausal PCO patients. So can inositols be combined with metformin? Of course, we have used metformin for many, many years before. It's an excellent drug in PCO patients. It suppresses their appetite. It enhances weight loss. And the extended release form works much better than the plain form, particularly in patients who have got GI disturbances. You can start with a low dose, maybe 250 to 500, and build it up to 1.5 to 2 grams per day. The maximum dose is 2000 milligrams can be tolerated. So how does metformin work? Given for 3 months along with diet and exercise will give menstrual cyclicity to almost 25 to 30% of patients, will cause a reduction in their BMI in the range of mean of 2.8, and will give spontaneous ovulation in 30 to 40% of patients at the end of 3 to 6 months of treatment. Metformin will reduce testosterone levels, will reduce insulin levels, and a significant benefit is because of the weight loss that is accompanied with metformin and lifestyle changes. Metformin is continued in early pregnancy. Initially, we thought that it will help us to reduce the miscarriage rate, which subsequent studies have not been able to replicate this study of 2002, but nevertheless, metformin is given in the first trimester because those patients have a higher likelihood of a greater live birth rate. So metformin is to be combined with a hypocaloric diet. It has an additive effect upon a low calorie diet, particularly in obese patients who have got abdominal or visceral fat, greater reduction of body weight with abdominal fat, and reduction in serum insulin, testosterone, and leptin concentrations is seen when compared to placebos. So meta-analysis of 2008 have shown that metformin alone showed a statistical increase in ovulation as compared to placebo with an odds ratio of almost 2.9, that is Metformin is almost 3 times better than placebo in giving ovulation induction, but did not give a statistically significant increase in early pregnancy or live births. But when it was combined with clomiphene citrate, or now if metformin is combined with letrozole, it gives not only a better odds ratio for ovulation, going up to an odds ratio of 4, but also a better pregnancy outcome with an odds ratio of 2.6 as compared to clomiphene or letrozole given singularly. So metformin will increase the likelihood of ovulation when combined with clomiphene and give you a better statistical pregnancy rates in women who are obese, PCOS, and treatment may not improve the odds of miscarriage, but when given in the first trimester, will definitely give you a better likelihood of a live birth rate. Now, when you compare a combination of metformin or clomiphene or metformin and letrozole as compared to gonadotrophins, obviously the gonadotrophins are much, much more potent and will give rise to a much higher incidence of ovulation and pregnancy ratios with an odds ratio of 4 in favor of gonadotrophins. But when you compare it with laparoscopic ovarian drilling or diathermy, the success of ovulation and subsequent pregnancy rates are almost the same in both procedures. Now, although we know that gonadotrophins are superior, it is very relevant to try metformin with clomiphene or letrozole as a combination in at least 3 to 6 cycles, and if not effective, the gonadotrophins can be introduced. However, the clinician may continue the use of combination oral drugs in places or situations where there is limited access to gonadotrophins, either because of less expertise to monitor and supervise such patients, or even because of the increased cost that is involved in the use of gonadotrophins. So recent evidence has shown that a subset of women who are given metformin, it is effective irrespective of their insulin resistance or glucose intolerance. Now, this is something which is important because we now no longer would like to confirm with blood test of insulin their insulin resistance, because metformin will exert beneficial metabolic, endocrine and ovarian effects, which is like an insulin sensitizer and which will help these women. So obese PCOs, even if they do not have biochemical evidence of hyperinsulinemia, can be given metformin because it will help them otherwise. So the pros of insulin sensitizers is it reduces the insulin resistance and addresses an important component in the pathophysiology. It will treat hyperglycemia in patients who are already diagnosed with type 2 diabetes, will help for weight reduction and improvement in lipid profile, is an option in patients in whom the combined oral contraceptive pills or the birth control pills cannot be given, like in factor 5 laden mutations where there's a risk of hypercoagulability. In lean PCO patients in whom lifestyle, like telling them to lose weight or go for exercise, may not be an option, but insulin sensitizers will work well. And the safety profile for metformin is excellent even in pregnancy. Now, we have some Indian studies where they've compared metformin versus myo and metformin in patients of PCO undergoing ovulation induction cycles. a fairly good amount of patients in both arms, 120 patients in both arms. Treatment in the first group was metformin 500 with myo-inositol 600 milligrams TID, and the second group was 500 metformin given 3 times a day. These patients, when you look at the patients who have received the combination in the orange red bars, you will find that they do much better with a combination of metformin and myo-inositol as compared to only metformin. To conclude on this metformin myo-inositol, we feel a combination has resulted in a significant improvement in clinical profile with a reduction in the dose in cases with PCO, particularly obese or severe insulin resistant patients, and they both give a synergistic effect causing a better action at much lower cost and can be an effective management for PCOS. The other crossroad that we reach is when patients, despite medical management, do not respond to the treatment, in whom the ovarian drilling could be an effective mechanism. And this is mostly resorted in the thin, lean PCOS where failed medical treatment or not much to offer, history of previous hyperstimulation when they were put on ovulation inductions. The pregnancy rates are as good as clomiphene and metformin, which is ovulation in 70% of the women, pregnancy in 6 months in 40%. But since it's a surgical procedure, risk of anesthesia, risk of adhesions, and over enthusiastic drilling of the ovaries can also lead to premature ovarian failure, which is a risk and which is something that we have to be extremely, extremely careful of. In which patients would you like to use gonadotrophins? Obviously, the ones who have failed to your oral ovulogens. So, 3 cycles of oral ovulogens and no ovulation, or 6 cycles which are ovulatory but no pregnancy, or where there is a severe disimpairment of the endometrial lining, be it clomiphene or letrozole, or patients who have got recurrent miscarriages to oral ovulogens and side effects irrespective of their ovulatory status can be then put on to gonadotrophin treatments. The recombinant gonadotrophins are better in PCO patients because they have can be given in smaller doses. They do not have the LH component, which is by far and large always raised in PCO patients. No risk of contamination, no risk of antibody production, can be self-administered by the patient and much purer, and hence there is no batch-to-batch variations. The other problem with PCO patients is the possibility of a premature LH surge. Now, in PCO patients, there can be either a premature LH surge, which happens, or they could have persistently high LH levels, in which case recruitment of follicles will not happen. And these are patients who typically do not get periods for 2, 3, or even 4 months and need to resort to withdrawal bleed with progestogens. These are patients in whom you would like to put them on 1 or 2 cycles of the birth control pill, particularly to get their LH levels down and also to thin and fluff off the old endometrium so that they will respond better in subsequent cycles. The other problem with PCO patients is that they can land up with having premature LH surge, particularly in those who have got multifollicular development. And this is a patient who you think has responded rather well. You give the trigger, but they do not ovulate because the LH has already prematurely surged and there is corpus luteum formation and raised progestogens. Thereby, there is dyssynchrony between the ovulation and the endometrial lining. In such patients, You could, in the subsequent cycle, measure their LH when the leading follicle is 14, because at that point in time is the rise in PCO patients that we can possibly see. And these patients then are given antagon at 14 millimeters, and the antagon is continued till they get the beta HCG. The antagonist used in IUI patients is premature ALH surge associated in pregnancy in IUI. It can be also used to restore the pregnancy rates in such patients in whom you think have prematurely surged. You can call up and tell them I'm talking. So, what is the eye opener in PCO patients? The eye opener is this multiple studies which show that the IVF uh, outcome or higher miscarriage rate is in PCOS as compared to non-PCOS who are down regulated in IVF is not associated with oocyte morphology or embryo quality or development and metabolic activity of pre-implantation embryos. It is basically related to their BMI. And hence, I think every patient has to be counseled to lose at least 10% of their weights so that their BMI comes down and they give themselves a better implantation and a better outcome in IVF or in any fertility treatment. So, management of an ovulatory PCOS is basically lifestyle modification, weight reduction by a hypocaloric diet and exercise, a weight loss of 10 kg or a 10% weight loss will result in decreased blood glucose, decreased insulin, androstenedione levels, thereby giving a spontaneous ovulation of almost 30 to 40%. And these patients, just by lifestyle, can get pregnant spontaneously. There is a certain group of severely obese patients in whom even walking a few steps is difficult because they are extremely obese, 120, 130 kgs, with a BMI of reaching more than 35 or even 40. In these patients, the use of anti-obesity drugs can be considered. The only FDA-approved drug for treatment of obesity is orlistat. It works through a mechanism of inhibiting intestinal lipase activity, thereby inhibiting fat absorption. The adverse effects is steatorias, flatulence, and patient compliance can be low because of this. But important is that they have to adhere to a low-fat diet, having their LFTs repeatedly checked to make sure it is fine. Bariatric surgery is now offered to such obese or severely obese patients. There are three types of bariatric surgeries, predominantly the malabsorption procedures, the restrictive procedures, or the bypass procedures. In whom is bariatric surgery indicated? As I said, bariatric surgery is indicated in patients with BMI of more than 40, in BMI more than 35 with coexisting comorbidities. They would lose around 20 to 40 kgs over 2 years. Bariatric surgery will even improve their menstrual irregularities, and some patients are known to spontaneously conceive, but we would like to wait for at least 1 to 1.5 years after the surgery because it also causes severe micronutrient and vitamin deficiency in these women. And I personally think it is not fair for them to conceive. We need to make them fit to have a healthy baby. So the three different types of bariatric surgeries are the sleeve gastrectomies, which is commonly done, the proximal gastric bypass, which is an extensive surgery, most often not done in women young or those who desire pregnancy. But the gastric bands are the best ones because these bands can be adjustable. These bands can be deflated in pregnancy so that they can eat, so that they have good nutritional and vitamin support to the pregnancy, and post delivery through a small port these bands can be reapplied and adjusted. So IVF after bariatric surgery can be safe, provided, as I said, the special nutritional requirements are met. Delaying pregnancy for 1 to 2 years is a very sound advice that we should give and counsel the patient before bariatric surgery so that we do not expose the fetus to nutritional deficiencies from rapid maternal weight loss. We have a series of almost 15 patients in whom we have done IVF after bariatric surgeries with excellent results. PCO is an evolving disease, and the more we come to know of it, the more therapeutic options, new pharmacological agents are offered. Statins is something that is now used in PCO patients. Vitamin D supplementation is something that is extensively used in PCO patients and also in patients with low reserve. And the other drugs that are tried are acarabose or dipeptyl peptidase. Let me talk a little on hyperstimulation. I think this is something that we all have to be aware when ovulation induction is offered to PCO patients. No treatment or stimulation protocol can claim impunity or say it doesn't give hyperstimulation. In my practice, I've seen hyperstimulation even with clomiphene and letrozole. Various ways of trying to predict, prevent, and manage PCOS. Use of cabergoline is something that we routinely do, doesn't reduce your pregnancy rates, but will definitely reduce the trigger that is done for hyperstimulation. And a sound advice would be sometimes to cancel the cycle, convert the IUI to IVF cycle, or freeze all the embryos in an IVF cycle. The AMH values nowadays helps us to interpret what type of treatment we would offer PCO patients. So PCO patients with very high AMH, more than 15, are high responders. They respond better to antagonist protocol, which is safe and which is more giving better results and better outcomes. On normal AMH, you could go ahead with a long protocol, and patients with very low AMH, like poor responders, you would again want to move to the antagon protocol. So to summarize, ladies and gentlemen, lifestyle modifications, pharmacological therapies, be it the birth control pill, be it the progestogen only pill to regularize cycles, clomiphene, letrozole, or any insulin sensitizers, combination of insulin sensitizers will work effective for ovulation induction. Surgical interventions, laparoscopic ovarian drilling, or bariatric surgeries. And as I said in the beginning of my lecture, monitoring and supervising these patients to prevent the metabolic X syndrome that can happen in peri or postmenopausal women. The guidelines of 2018 by far endorsed the Rotterdam criteria, but they highlight that ultrasonography is not necessary in diagnosis, particularly in the young adolescent patients in the first 8 years after their menarche, because most of the ovaries would look PCO or multicystic. AMH is not necessary for diagnosis, mainly because it's a very sensitive test and needs better platforms and stability. Management of PCO is for reproductive, metabolic, and a big arm is psychological counseling, educating the patient, educating the patient's family, empowering the patient to self improve and self empower themselves with the knowledge that if they modify their lifestyle, they will do a large good to themselves. Multidisciplinary care, having dietitians, nutritionists, counselors, psychologists talking to these patients who sometimes can have very low self image, lifestyle interventions for excess weight management. The birth control pill is a first line of pharmacological management for menstrual irregularities and even hyperandrogenemia. Low dose is to be preferred. If the birth control pill doesn't work on hyperandrogenemia after 6 to 9 months, you could then move on to anti androgenic pills. Metformin alone or in addition for metabolic features. Letrozole remains as a first line of pharmacological treatment for infertility and ovulation management. CC and metformin have a role in combination or can be given alone. Gonadotrophins, the second line, and IVF as a third line when all other treatments have failed. Thank you very much for a patient hearing. I'm very happy to take any questions that can be asked.
Thank you, sir.
Thank you,
Thank
sir.
you for your excellent and very superlative talk. It is always an honor and learning to hear you, sir. Sir, if you allow me, then we will have a quick question and answer session.
Yes, we can go ahead with the question answer
Yeah,
session.
yeah. If any questions are there in the comments, I'll just read out for you. So there's a one question: uh, whether statins have any role in PCOS?
Yes, so I just said that statins is something which is very new. It is being tried in various PCO patients, particularly the very obese PCOs, those who have got lipid derangements. But if you are looking at treatment for infertility, I would like to stop the statins when I start my stimulatory cycles. We have treated patients for 3 to 6 months prior with statins if they have got hyperlipidemias, because in pregnancy, as you know, the lipid levels will further rise, and that can itself be a risk to the patient, or patients with hypertension who are already got comorbidities. Statins work very effective.
Yes, thank you, sir. And, we have one more question. How is late onset congenital hyperplasia due to 21 hydroxylase deficiency differentiated from PCOS?
Yeah, so you have to do their blood test for 21 hydroxylase progesterone. It is a rather expensive test, and uh, uh, late congenital adrenal hyperplasia is not very common, but yes, you will have to do their blood test for 21 hydroxylase progesterone, and that will help you to differentiate between PCOS and congenital adrenal hyperplasia, the
Yes.
late onset, not the congenital.
Yes, sir. So we have one more question. Should we advise IVF as a first line in or with very high AMH more than 20?
To be very honest, yes, you do have some odd patients in whom you know that giving them clomiphene and letrozole is not going to help. If you start them on gonadotrophins, they would need the low chronic dose for multiple days before they actually show any signs of even a single monofollicular growth. And in these severely PCO patients, you could offer them IVF as a first line, understanding that they will hyperstimulate, and you may have to go for all freeze or cryo preserve these embryos and then use them in a frozen thawed cycle. You must understand that these patients, the oocyte quality is also not very good. So you may want to treat them first. As much as possible, try to put them on some diet, exercise, weight loss. They may not have that 10% or 10 kg weight loss, but as soon as they start losing weight, You could put them on myo-inositol also. And as soon as they start showing some weight loss, you could take them up for the IVF treatment. But I would not say that this should be done for every PCOS. These are reserved for those very, very severe PCO patients where the ovary actually looks like a honeycomb ovary, where you know that giving them mild stimulation is not going to help. You have to give them little high dose, and the minute to cross their threshold, they will hyper respond, and you may have to cancel their IUI cycle. So then, in such patients, it is worth putting them on IVF in the first instance, explaining to them that you would like to cryopreserve or freeze all, and then go for the third embryo cycles.
Yes, sir. Thank you, sir. And we have one more question. How to assess if a woman PCOS has a chronic grade inflammation?
Chronic low grade inflammation. Now, you
Yes.
must understand that PCO patients, PCO also is an inflammatory reaction in the body. And that is why PCOs are also, it is like hyperlipidemias can have an inflammatory component, and that is why they have this sludging and they have this platelet aggregations and thrombi formation. So PCO does have an anti-inflammatory type of reaction, but it is no low-grade infection that you need to treat with antibiotics. This is part of the pathogenesis of PCO.
Okay, sir.
If
Thank
you
you, sir.
measure that TNF alpha factor or you measure their interleukins, you will find that they are raised like they are raised in inflammatory diseases.
Thank you, sir. And there is a question from Anita Jaydev. High AMH levels associated with the premature LH surge.
No, AMH levels are not associated with premature LH surge. As I said, on history, you would get a history of chronic anovulation or prolonged periods of amenorrhea. In such women, you will have persistently high LH levels. The LH levels do not drop down, and that's why they do not get a proper withdrawal bleed. They'll just get a bit of spotting. And these patients need to be given COC to get their LH levels down and also to slough off the endometrium. If you scan them, you'll find that they have got hyperplastic endometrium. The other group is the group where you have multifollicular response. So the brain thinks that once a estrogen level is reached, it would release the LH. And multiple small follicles will give you that estrogen level, which may be given by one mature follicle. And that's why in a multifollicular response, you have a high chance of getting premature LH surge. And in those patients, the antagonist works very well, particularly when the LH rise starts when the dominant follicles are 14 millimeters.
Thank you, sir. And there's a one more question. Is clomiphene citrate or metformin effective in reducing the hirsutism secondary to PCOS?
It will not help you to, it will help because metformin will also reduce your testosterone level. So to a certain extent, it will help. But if the it depends on the grade of hirsutism that is there or the grade of andronization. So if they have got mild hirsutism, mild acne pimples, metformin weight loss will help to reduce their testosterone levels. It will.
Yeah. Uh, Thank you, sir. And we have one more question. Does vitamin D deficiency increase the risk for metabolic syndrome in women with PCOS?
Yes, as I said, there is now research on vitamin D, and we particularly see that there is vitamin D deficiencies in PCO patients, and the other spectrum is patients with low ovarian reserve. So in both the extreme groups, we find that there is vitamin D deficiencies, and supplementation of vitamin D is one of the therapeutic modalities, even in PCOS. My last slide did mention the newer things that are happening in which statins, vitamin D, and acarabose is mentioned.
Yes, sir. Thank you, sir. And please share the criteria to start metformin in adolescents. should be followed with LH or fasting insulin?
No, as I said, if they are obese, first and foremost is to encourage them to lose weight by lifestyle modification, that is diet and exercise. If you do their glycosylated hemoglobin and it is high, you could put them on metformin, starting with a low dose, but only metformin is not going to help. Metformin has to be supplemented to their diet and exercise, which is extremely important in an adolescent person who is embarking on their career, maybe for fertility or various other reasons. So, in an adolescent patient, myoinositol with metformin will work very well if they are obese, but understanding that we have already told them about diet and exercise.
Yes, sir. Thank you, sir. And there is one more question. How to assess gut dysbiosis in PCOS
How
patients?
to assess?
Gut dysbiosis. Whether the patient have a dysbiosis in PCOS patient.
I didn't understand what biosis.
Gut dysbiosis, sir.
Gut dysbiosis.
Yes, sir.
What does that mean? I have no clue.
Uh, I mean, yeah, actually, this is like whether there is a. Hello?
Yeah, so Prachi here from Shield Healthcare.
Yeah, yeah,
Uh, so we, because of inflammatory condition in PCOS is considered as a chronic inflammatory condition.
yes,
So there are a lot of papers
yes,
which indicate that it is associated with the microflora within the
yes,
gut
yes,
is
yeah. So
disturbed.
those all are theories that are happening now, but there is no
Correct.
established treatment that I can tell about the microbiome, because now microbiome is something which is uh, coming into fashion for even implantation failures. So you have lot of
Right, sir.
this natural uh, products that you would want to give people, probiotics as we call them, which will help
Right,
the
sir.
gut flora to get better and reduce the inflammation. Yes, that could be
Right,
something
sir.
that can be tried, but I would not suggest in each and every PCO patient.
Right, sir. So, any indications where you suspect that
If I've got
gut flora
patients,
is
yeah, if I've got
clinically?
patients, yes, if I've got patients with Crohn's disease, if I've got patients with any autoimmune problems, if I've got patients with irritable bowel syndrome, I've got patients with some bowel
Hmm.
symptomology along with PCOS, yes, I would think on those lines and treat them accordingly.
Right, sir.
Yeah. Uh,
Right, sir. Thank you
thank,
very much.
thank you, sir. And sir, we have a question from Dr. Aditi Kapadi asking a young 16 years patient with acne as a main symptom along with irregular menses. What would be the plan of action?
See, we would want to start them on the birth control pill. 16 is the right age to start them, because we do not want to start birth control pills very early at 10, 12, and 13, because it can cause early ossification of their bones and may reduce their height. But at 16 years, it is safe to start them on some low dose third generation pill. It will take care of their periods. It will definitely take care of their acne and pimples and all those things. So you could start them on the birth control pill, very easily available, cheap, and very easy to take. And low dose pills give very low side effects, and they can be taken for many years together till she can be afterwards can be used for contraception also once she gets into sexual activity.
Thank you, sir. And we have one more question from Dr. Anita J. Dev. What is the criteria for giving metformin in lean PCOS?
Yeah, so now the lean PCOS, as I said in one of my slides, I showed that 30 to 40% of lean PCOS also have insulin resistance and hyperinsulinemia. So metformin is given for that reason. And I also said that nowadays in obese patients, almost 80 to 85% of them will have insulin resistance. So in thin, lean patients, metformin will work if they lie in that group of 30-40% who have got hyperinsulinemia, even if they're thin and lean. If they do not have hyperinsulinemia or they cannot tolerate metformin, myoinositol also works equally well.
Yeah, thank you, sir. And we have one more question from Dr. Bhavana. I think it's related to the previous question. Adolescent girl with irregular periods, non-obese PCOS, how to treat?
Yeah, so if she's got irregular periods, if you have ruled out any other cause for irregular periods like hypothyroidism, if she's non-obese, then all your Cushing's and all those things will automatically go off. You could treat them with the birth control.
Yes, sir.
After the age of 16, 18, I think birth control pills are safe to be given to these girls.
Yes, sir. Uh, Thank you, sir. And I don't see any more additional questions in the comment box, sir. Sir, if you allow me, then we will close this webinar.
Thank you so much, and thank you to all the viewers, and thank you to Shield Health and all their supports. Thank you to Mr. Prasad, who has taken the effort to be online with us, and all your back office team who has conducted this program and brought it to
Thank you,
all
sir.
of you.
Thanks so much.
And congratulations again to you on your Shield Connect. I will definitely go onto the website and look up your other lectures that are there. And I think it's an excellent tool, not only for postgraduates, but even for practicing clinicians if they want to refresh some of the lectures that they may have either missed or want to listen again. So thank you once
Yes.
again. You all have a very great evening. Be safe, be healthy. Thank you.
Thank you, sir.
Thank you, sir. Thank you very much, sir. And many thanks from the Shield team.
Thank you.
Thank you, sir. Thank you very much. And especially those question and answer session was very, very helpful. Thank you
Thank
very
you,
much.
Dr. Prati. Bye.
Bye bye, sir.